Hi, everyone. Welcome back to the 2020 Brain Health Online Summit. I am Amy Zellmer from Faces of TBI and the Brain Health Magazine. And those of you who don't know who I am a survivor from a fall on the ice in February of 2014. And myself, along with my doctor, Dr. Jeremy Schmo from the Functional Neurology Center, we saw a need in the brain injury community for more training and education on alternative healthcare methods and modalities for those suffering from the lingering effects of a brain injury. So each weekday during the month of March, you're going to hear from a presenter who will share either their real life experience living with brain injury or their experience working with brain injury patients. And today we're here with Dr. Brian Sass. And Brian has been working with the most complex patients from all around the world at the Functional Neurology Center. He is a fellow of the American Board of Brain Injury Rehabilitation. He graduated from Michigan State University with honors in 2011 with a bachelor's degree in human physiology. He graduated magna cum laude from Life University in 2015 with a doctor of chiropractic. He was awarded a Certificate of Merit in Contemporary Scientific Paradigms from Life University. In 2015, he received fellowships in brain injury and rehabilitation, as well as a diplomate in functional neurology from the American Chiropractic Neurology Board. He is also a certified functional medicine practitioner, and over the past 8 years, he has taken thousands of hours of courses offered by the Carrick Institute of Graduate Studies, focusing on neurology and patient-centered rehabilitation. So welcome back to the summit, Dr. Sass. Sorry.
I'm happy to be here.
Well, today you're going to be talking about the week-long intensive. And I'm excited to share this information with people because it's been fascinating for me coming in once a week and seeing patients and just seeing the amazing changes that can happen in that week. So I'm really excited to have you share the magic that goes on behind the scenes.
So it should be a good talk because I think a lot of people don't really know what to expect. They don't really know what we do, why we do it. So I thought I would do just that. I want to talk about what exactly we do, why we do that, and actually give some examples of real life people that have come in, some of the testing that they did pre and post treatment that'll hopefully shed some light on what we do here.
Awesome.
So I guess to start off of what we do, I guess it's best to talk about why we do it. So I guess our mission from a general standpoint is to change and improve brain function in order to reduce and eliminate symptoms. So if that's our goal, we can look at it like that's what we want to do, like dream wise, like if we could build anything, how would we do it? So I guess starting, I wanted to pull a research article that talks about what's known on the topic of changing and improving brain function. So the technical definition of that is called neuroplasticity. And the first thing that I want to talk about is it was really discovered and accepted in the early 1970s, meaning before that, and then 50s and 60s, people thought that if you injured your brain or you had any type of trauma or illness, they gave you dizziness or something like that, that if it didn't go away in time, you were stuck with it. If you think about playing cards, like the old saying that you have to play the hand that you're dealt. Well, in the early 1970s, there was this guy that did these experiments that was trying to prove that. And every experiment that he did, he couldn't prove that the brain didn't change. So ever since that time, it's been accepted and it started to change some of the paradigms that, you can actually do treatment and have brain function and brain structure change. So the last thing that I want to say about that is, when you think about it, like if you go back in the 50s and 60s, if that was the mindset, like every neurologist, every doctor, therapist, whoever had in their mind, like if you walked in the door, they would be thinking their brain can't change. Like there's no way that these symptoms will go away unless if they go away on their own. So every treatment that I do is either going to try to mask what they have or just try to manage it. So what we try to do is the exact opposite of that, where we actually try to fix it, because we know that it's at least possible, or there's potential or a high probability with a lot of people that even though they might be suffering from some symptoms, if it's a functional issue, meaning like it wasn't a stroke or something, there's a high chance that if you do the right type of therapy, you can actually get a lot of that function back, if not have a full recovery. So the article that I pulled for the reference from this is, it was a review of the literature from the Journal of Neurology, and they defined neuroplasticity as the ability of the nervous system to respond to intrinsic and extrinsic stimuli by reorganizing its structure, function, and connections. The important thing to note there is there's a lot of factors that can change it, but it's not just changing the function or overriding something. It's the structure, function, and the actual like connections between different areas of the brain. What they concluded, actually, they go through different mechanisms and different strategies and things like that, but they came to the conclusion that neuroplasticity is often experience dependent, time sensitive, and it's strongly influenced by features of the environment. So to kind of summarize that, like there's two main points that I want to talk about that, again, like if we go back to the main goal of we want to change and improve brain function, there's basically two things that need to happen. The first one is the matter of time. So the key to the time issue is it has to be frequent and it has to be repetitive enough to actually cause a change. If it's too far apart in times of duration or time or something like that, it lessens the probability that you'll actually create a good brain change or a good brain function. A good example of this is, let's just say that you come to the clinic and you're like, okay, the doctor says, I want to see you for 15 visits. There's a difference of if you do those 15 visits in 3 months or you do them within a week or two. So the first way is, if it's truly time sensitive, that these neuroplastic changes are time sensitive, we want to make sure that within reason we can make it as frequent and as repetitious as we can to help promote that.
Yeah.
The other one, which is probably just as important, if not more important, is the experience or the environment. So I lump these two together, and the best way that I can describe this is it has to be the right type of treatment. Meaning, like if you have a problem in one area of the brain, you might do the best types of treatment, but if it's not really specific or it's not really designed to integrate or change the processing of that brain area, it'll never work. Like let's just say that you came in, you're like, I have brain fog and I got really bad headaches. Working on just your balance or something like that might not change enough of the brain or the injured brain areas to actually cause a change. So that's more on the doctor side of it, is they have to evaluate it and say, this is what you need, or this is what we have to do in treatment to make sure that it's the right type of treatment that will change what needs to be changed, instead of doing like a general kind of let's throw everything shotgun approach and hope something sticks.
Right.
So anyways, so with those two key features in mind, what we came up with is the intensive week. So we call it the intensive week, even though it's kind of misleading, because it's not, like people hear intensive and they're like, oh man, I'm gonna go, it's like boot camp or something. I'm gonna go, work out or something for the whole week. But we call it intensive because basically what it is we do it over a string of 5 days, and it's basically 3 hours a day. So there's usually like three sessions a day, and they're spread out by a little bit of time, but they're relatively concentrated and saturated. So there's a high volume in a relatively short duration. So it's intensive in terms of the volume and the duration versus what you're actually doing, which I'll talk about. So as a quick kind of overview of what the intensive week would actually look like, the first day that people come in, usually like the first 2 sessions we dedicate to testing. So I mean, for like me personally, I like sitting down with people for a while and then talking about their history, their symptoms, what it feels like, what they think's wrong, like what has worked, what hasn't, things like that. I really take a lot from that, and it's something that when you when you start to understand how different injuries occur and different patterns of different brain areas, it's like you can usually listen to it and have a pretty good idea of what's going on. So we usually spend a lot of time doing that. And then the rest of that session, and then the second session is either diagnostic testing, which I'll show you examples from later in this talk, or the physical exam, which is probably somewhat similar to what you might see at a neurologist's office, except we do it in terms more of, we try to challenge different tests and see if we can change it. I tell people, like, if I, like if I'm doing like a finger to nose or some kind of test, and like, let's say like they're way off with their right hand, I'll sit there for a while and then try to make it normal. Because if I can make changes like that or challenge the system and then have a good outcome, there's a better chance that I can help them, or like our treatment's going to help them. So usually like I'll look and, try to find things that aren't normal that might, have something to do with their symptoms. And then I'll sit there for a while and then try to change it. But anyway, after those first two sessions, that third session of the first day, I sit down with those people and I show them all the testing that we did, and I'll explain it. Sometimes in more detail, sometimes just a general overview, depending on what they want. But it's important to me that people know what we found and like what the plan is for the week. So I make sure that we spend some time doing that as well. And usually there's time that third session to do some sort of treatment that first day. Beyond that, the second, third, and fourth day are basically all treatment, meaning each session is just dedicated to purely treatment. And each session won't necessarily be the same. It's not like we're gonna do the same thing over and over and over again. They'll be a little different, but what I like to tell people is usually there's a few things, whether it's like the vestibular therapy or more the proprioceptive therapy or the autonomics or whatever, there's usually something that we have to spend more time on. Like if that's the main system or like the main injury, we'll dedicate more time to that instead of, this protocoled out and we only have so much time for this and so much time for that. It's flexible, meaning we can sort of do whatever we want based upon whatever we think you need. And then the final day, what we'll do is we will retest what we did the first day. So it's almost like that first day, those tests that we did, that's kind of like a baseline. Then we do all this treatment and then we retest it again. And then what I'll do is I show people that and I'm like, this is day one, this is today's, and let's see if it's different. So it's a true objective test of, did anything change? I'll talk more about the testing that we do too, because like they're more brain function tests. So it'll make sense when I talk more about that. But instead of just like how you feel or I think you're doing good, it's like, let's just put it to the test. Let's see what it looks like. Let's see what changed, what didn't, because then, so that final day again, like we'll do like the retesting and talk about it. We'll go through some more treatment, but then I give people home exercises based upon how they've done the week, but also based on that testing. So I always tell people, it's like they always freak out when they're like, oh my God, I'm going to leave and then I'm on my own. I make sure that when people leave on that last day, like they know exactly what to do for the next few weeks, if not like next month or two.
Yeah.
And there's, check-ins and things like that. So they're not like on their own doing things, but people feel pretty good when they leave, that they have a handle of what to do, what to work on, how to do it, things like that.
Yeah. And I know, at the end of my intensive, I was sent home with my exercises, and in the beginning it was hard for me to remember to do them because of memory problems. But then, doing them, I mean, they take minutes. They're not like long and complicated. But I know over the course of the next like 8-10 months, I had way more improvement. Yeah. So they're important.
Yeah. Which is important, where I try to look at it like when people come in, I want them, or like what I try to do as a physician or doctor or whatever, is I try to heal things or stabilize things or fix things that they can't do on their own.
Mm-hmm.
Certain things, especially when you deal with the brain and brain injuries and things like that, people can't fix them on their own. Like if they could, they would just stand up, walk around, get in the car, turn around a couple times, and then they'd be healed. Like what I try to do is I try to fix that kind of stuff. And then even though it might not be 100% healed, there's a lot that you can do on your own if your brain's in the right place for it. So my goal for everybody is to stabilize them enough, or heal them enough that they can take the home exercises and keep improving on their own, with the hope that they go home and they don't need to do any other treatment. They just do that, give it some time, and then they like recover. Doesn't always happen, but sometimes it does.
Mm-hmm. And, do some people need more than 1 week of an intensive?
Some people do, and to me, it's very hard to predict, because
Yeah.
like if I even if someone calls me and they're like, I've had this for years, or I got knocked out and I was unconscious for this amount of time, or I have 20 symptoms instead of just 2 or something like that. It's very hard to predict. Where for me, what I tell everyone is, you may or may not, but I'll know more after we do the first week,
Yep.
where you started from, what we did, what it looked like, and then how you felt afterwards. Usually I tell people, give us some time, even like a couple weeks after, because you don't really know. Like sometimes it's gradual and it just keeps going. Sometimes it's like, really quick and then it just goes away. Or, sometimes it's more tricky up and down, but it's more of like, I tell people that after that first week, or if we keep them for 2 weeks sometimes, just because like they would really do well with more treatment, like right off the bat. I tell them, give it some time. And if you feel you need it, or if you hit a plateau, you're like, man, I've been doing all this stuff nutritionally and exercise, my home exercise, I'm doing all this stuff, but I'm stuck and I can't make progress, but I'm almost there. Cause like usually what happens with people is they'll get, 80, 90%. And that last like 10 or 20%, they're like, God, like I can't get rid of it. It's almost there. I know it's almost gone, but whatever I'm doing at home, I've tried all this different stuff, but I can't get it. That's when I'm like, come back. Cause like we can usually make that last bit go away.
Yeah. Yeah. And I know for me, I did a less traditional intensive. I think I did 3 or 4 weeks. I came like 3 times a week. That was before he had established the week long. And I did my exercises at home afterwards. And I had one really big setback. I had a really major flare up from driving at night with like those reflectors on the road in South Carolina.
Yeah.
Totally flared me up, and I could not bring it back down with my exercises. And so I went back in, and it was literally a 1-hour session, and he nailed it. And I like people to hear that, because you can still have a flare up. It can still happen, but it doesn't take another week to bring it back down.
Right.
Sometimes it might, but usually.
Yeah. Sometimes it might, but usually depending on people's cases, it's like if it's pretty stable, or you see significant quote unquote improvement, 50% or more, then I look at it like, and it's normal, meaning like you'll have good days, like you'll have bad days, but usually people don't go back to square one, where it's like, oh man, I did, I worked out too hard, or I went to Walmart or whatever store and I shouldn't have, and like the aisles or the lights or the noise got me. It's not like you just lost all the progress you made. Because like people sometimes worry about that. They're like,
Yeah,
eggshells, making sure they don't do too much. But I'm like, once you really change the brain and you stabilize it, meaning you make a good change, and it's not in that like kind of like limbo where it's still changing. Things are pretty stable. I mean, short of getting another bad injury or car accident or something where it truly injures it again, it doesn't really go backwards. So
yeah.
So on that note, though, I did want to talk about, sometimes people have, questions about it. So I thought I'd talk about some common questions people have,
Yeah.
about our treatment or the intensive week and things like that. So probably the, like one of the more important ones is, people always ask, it sounds great, you do all this brain stuff or whatever, but what should I expect in treatment? Because a lot of people that come to our clinic have been in other places that claim to do the, brain treatment. And, for whatever reason, it hasn't worked. So the best way for me to describe this is, there's a difference when you're doing treatment, when you're trying to improve, or you're trying to, hone a skill, versus truly like performing some sort of like rehab exercise. So the best example I can give of this is, a lot of people come in and they'll have like blurry vision or double vision or headaches or something like that. And they'll usually, either with like a PT or like an eye doctor, they'll usually do a convergence test, where the doctor will sit out in front of them, and then with their thumb or with a pencil going close towards their nose and then far away. And usually it's very common for that eye movement where both eyes come in and then both eyes come out. That breaks down in a lot of different things. So what they'll do at other places is the doctor will sit there and be like, oh, there's something wrong with that. And then they'll tell that person, I want you to take a pen, and I want you to do that over and over and over again until it's good.
Right.
So I would classify that as like you're trying to teach or train a skill, meaning I notice that you're not good at something, so I'm going to have you do it over and over and again with the hopes of somehow your brain figures it out and then you can, right? So I tell people, like, we don't do that at our clinic because a lot of people call in, and when they do that, it either doesn't work and or like they feel awful doing it. Like they're like, I just feel awful. They're like, I hate going there. I'm really nervous about coming to your clinic for an intensive week because it sounds hard. And I know that after, 30 minutes or an hour with other people, I feel awful. So like, what am I going to feel like? So I tell people, instead of just trying to train a skill, we look at it differently. Like with that same example, that eye movement or that function, there's a brain area that literally coordinates that movement. So it could be like an eye problem. I mean, it could be. But if it's not, instead of just working that one thing, we'll actually look at the brain area and say, what else can we do to integrate or, change the functioning of that brain area and heal it and stabilize it without doing the one thing that you're not good at. And then maybe later in time, do that same test again to see if it's different. That's an important key because a lot of people, they don't know what to expect.
Right.
But that's the difference between something working and something not, and then, possibly feeling better and then feeling awful. So I tell people a lot of our treatment is just from a general standpoint, it's designed to rehab or, heal the brain instead of just, we're not searching for you, or it's like, it's not an outcome if you can do something like stand on one leg or whatever. It doesn't matter. It's more of like, are those brain areas functioning as normal or as with as much integrity as possible? Or is it like, no, like that's still injured, even though you can do something really well. And then the other part too, that kind of goes along with that is in terms of outcome, because a lot of people, they're like, I took the impact test or I took, whatever kind of thing where I filled out. How do you know if I'm better or not, other than like how I feel? So I tell people, well, like we do our diagnostic testing, we have this objective testing with goggles and all this other stuff. And then people were like, why is that a good outcome? Like, why should I trust something like that? And I tell people, like, the answer is usually, most often with people, like we'll test different eye movements, which I'll show you later, but we don't do those eye movements in therapy. We might, but it's not like we sit there the whole time and then just do that one eye movement over and over. So on Friday we can redo it and be like, oh my God, it looks amazing. And whatever. We usually do the test on Monday, do other types of therapies that again integrate in those brain areas, but through different pathways and different circuits. And then we retest that same test again that we did day one. So it's a true look of, is that function better? Instead of like, did you just learn how to move your eyes better? So, so like on some way I tell people like our outcomes are at least designed to be more of a true, outlook of the system versus again, just a skill of, we taught you how to look to the right better, the whole week. And now it looks better, even though you don't feel any better.
Yeah.
And then like the other part, people usually ask that kind of goes along with like the intensive, name, is a lot of people we see are either, feeling awful or they're very, very tired. They're like, I can't get up out of bed. I sleep 12 hours a day. Like if I go to the store, I'm exhausted for the rest of the day. How in the world am I ever going to go to your clinic and do this treatment and not collapse and, whatever, die or whatever.
Right.
That there's a few aspects to this that, that make this efficient or beneficial for people. The first one is a lot of what we do is passive, meaning I tell people what to expect on Monday for like the rest of the week. Your job is to come in. It's either to lay down on a table or it's to sit there in a chair and you won't be doing anything else. A lot of it will be done to you. So you're not actively coordinating a lot of this stuff. So it's not necessarily physically demanding in that sense. A lot of people think that it will be, but it's not. also too, on that note, like when you do things passively, it's usually a better way to do it when there's a brain injury in the first place anyway, because again, if you could actively do something, like if it's like, oh, I'm just going to go turn around and walk down, walk in a straight line and then go watch traffic, and you could fix it, you would just do that and then feel good. So instead of making you do something that has a low probability of working, instead it's more of like a passive feedback that we're like giving you different stimulus and different inputs to try to reorganize or remap certain areas instead of having you coordinate that activity. That's important. Part two is our treatment isn't designed to increase symptoms. A lot of people have the mentality of, you're going to feel worse before you feel better or whatever. And it's like, that's not how it's designed. Some people may experience increases in symptoms, but a lot of people don't. The only thing that people usually feel during the week is they feel pretty tired. They're pretty wiped out, where I usually tell them to, even day one, like, I want you to feel really tired, because in a way, if we're truly changing, like if we're making your brain change, it's going to want to sleep. It's going to want to rest, because that's when a lot of the healing actually occurs. But you should actually feel better. The best example is people with headaches. By the end of the week, more often than not, they'll feel exhausted. They're like, man, I feel like I just, did the most challenging thing. And it's like, I'm just so mentally drained, but their headache's almost gone. Where they're like, usually, like if I did anything, like if I went on the computer, I like had to write emails, or I went to work or went to school, I'd be toast for the rest of the day, and my symptoms would be more. There's a difference of feeling exhausted or tired and having lower symptoms versus feeling exhausted and wiped out and having your symptoms, flaring like crazy.
Yeah.
So yeah, I mean, it's something that we try really hard to make sure that people don't feel bad. It's not the goal. It's not like, you have to go through these peaks and valleys. People always will to a certain extent, but usually if you're doing the right thing, people feel better when they're doing it. Like their bad days aren't like what they used to, and their good days are better than what they've experienced in the past since their injury. So yeah.
Yeah, and I think, Brian, that's the biggest question I get, because I get asked a lot about my experience there. And I think that's the thing, the most people are what the people are most hesitant about. They're like, I don't think I can handle it. And I'm like, you can handle it. The first couple of days you might be really, really tired, but then usually by Thursday, like a switch flips and people start feeling better. So it's so cool to watch.
Yeah. Yeah, which is interesting too. I mean, like my own experience, which is anecdotal in a way. I've treated concussions, brain injuries different ways, meaning like, which I've done it where it's spread out over 2 months, 3 months. I've done the intensive week a lot. I've done everything in between, where like, it was once a day for 2 weeks, or twice a day for the first week, and then once a day for the next week. There's just something about it, at least for me. Like if someone came in and they're like, from a general standpoint, because like there's always exceptions, but from a general standpoint, I have a concussion, I have a brain injury, I have these symptoms. What's the best thing in my, like, what would benefit me the most? I would say do the intensive, because I've seen that work better with almost everything. Like, which I wish that we had like alternate dimensions, or like a time machine where we can do one treatment and then like warp back in time,
Right.
and do the other one so we could really look at it. But since I've seen a lot of different approaches, there's just something about that kind of saturated, concentrated treatment, high volume in that short amount of time. There's something about that it's like, I don't know, which I think of it like we make the brain change instead of giving it time to kind of fall back in its comfort zone of like where it wants to be. Because a lot of people, again, like if you come in and, again, like let's say you have like brain fog, or you have a headache or something, some kind of pain, like I've had it, like I had a concussion 3 months ago, and ever since then I've had these symptoms. The only thing really going against you is your brain has found that to be normal. Like that is its comfort zone. That's where it wants to be. It thinks that that's the way it should be. So part of what we have to do, and why it's so important that we get the symptoms down, is we have to change that and make your brain realize like it's not normal to walk around with, a 5 out of 10 headache every second of every single day. So, breaking that, like there's something about it where if it's too spread out, it seems like people would, maybe get a little bit better, but then go right back. and then they come in for a couple, treatments or whatever, and then feel better, and then go right back. Instead, I look at it like there's no, like we don't allow it to fall back on anything. Like we make a change, make hopefully like a huge significant change where once it changes, like it never really goes back, and then it's just a matter of time before it's gone.
Yeah.
So any questions about anything about that before we move forward, Amy? Cool.
No.
So
You're a rock star.
what I wanted to talk about next is I have 4 patient examples of people that I've worked with personally. And I'll go through a little bit of their case, but more importantly, I want to talk, or I'll show you on the video some examples of their testing pre and post. So, let me get this thing started. So this first person, she was a 58-year-old female. She came in with a traumatic brain injury where she fell back in her bathtub twice and she was knocked unconscious.
Wow.
So we saw her a few months out. I think after her second one, I think we saw her 3 months after that. Her main symptoms were extreme fatigue, where she couldn't really do anything. She would, do a little bit per day, but then basically just like lie in bed all day because she felt so bad. Like any activity just really drained her. And then she also had dizziness, which was more disorientation, kind of floating. Like it wasn't vertigo, like spinning, but it was just more, she didn't feel stable. Like she didn't feel connected to the ground. She just felt off constantly. She had blurry vision, which was hard for her to describe. She's like, things just aren't clear. She didn't see double. It's just blurry, and it was basically all. Yeah. And it's hard because like a lot of people with that, like they'll get eye exams and like, we can't see anything wrong with your eyes. Like there's nothing wrong, but yeah, you still have this blurry, this like blurry vision. She also had headaches on and off, and constant brain fog. So like she was just walking around. I think it was like 4 or 5 out of 10, just constantly, and it would get worse if she did too much and then she got tired, but it would never really get better. Like that was kind of its baseline. So what I'm going to show you here.
Excuse me.
So this is her, this thing keeps playing. This is her VNG. So there's a test that we do where we put goggles on people, and what it does is it video records their eyes doing different things. So then we can actually show them the video and say, this is what your eyes look like when you're doing this or doing that, so people can actually see it. So what I'm going to do is I'm going to try to make this big. So first and foremost, when I hold this up, the eye that's over my finger here, that's her left eye. Okay, so I'm going to play this. I might try to hold it up. I'm going to play this, and what you're going to see is these tests are when she's looking left and right. I know you're kind of missing it. So this is when she's looking, I believe, at the right dot first. And like the dot's not moving, she's just staring right at it. And you can see even like with her eyelids, like she's struggling a lot just to keep her eyes open. So that's like to the left. And again, like the whole time I'm telling her, like, keep your eyes open, look at it, look at it, look at it. And she's trying really hard.
Wow.
She can't even keep her eyes open looking at it. So this will play, like the next test is called a pursuit test, where the red dot would move left and right slowly, and then she would just follow it with her eyes. So this is kind of like a tracking test. So you'll see me like as I'm going through this video, which I make the eyes bigger so you can see it. So like the first few tests were just gaze, where like she was just looking at the dot not moving. This test, when the dot's actually moving, and again, she's trying really hard. And if you see it, like her left eye, which is this one over here, you can see how it's a little bit more droopy than the right one. Things like that are important because it kind of tells us what's going on with the system, or at least it's one finding. So you can see her like struggle through it here. And then there's one more test where
are her pupils different too?
Yeah, like they're different sizes. I think that the left one was bigger.
Yep.
Which a lot of people have that. Like you'll see that in the next example too. But here are the Optogenetics, left and right. So this is the one where it's a test of visual motion, where we have a whole bunch of dots on a screen and they move first to the left and then secondly to the right. And this is more of a test of, can your brain respond correctly to a stimulus of visual motion even though you're not moving? So you can see that again, like she's trying to do it, but she just can't do it. So anyways, this is just one test here, but we evaluated her, figured out what was going on. And then, before I play it, so then 5 days later, or I guess 4, depending on how you look at it, these are the exact same tests where it's horizontal gaze left and right, horizontal pursuits, and then the optic kinetics again of the same person doing it. So this is her looking to the right. Is it playing?
No, it was just, yeah.
Let's do that again.
So she's holding her gaze.
Yeah. I
Yep.
couldn't tell.
Yeah, it was
Sometimes
moving
gaze
at
is
the
hard.
bottom. There you go. Yep.
Yeah. As long as it's moving on the bottom, that's good. So this is her looking to the left. So again, like if you remember like what it looked like the
Yeah,
first day
she
where
couldn't even keep her eyes open.
ways of doing it. And those tests should look like that. Like you really shouldn't see anything. Like there should be no eye movement, nothing like her
No
eyes just
jerking.
right. So this is the next test where she's pursuing or tracking that red dot left and right, which will blow up the eyes here. And same thing, like if you remember, she had a lot of trouble doing it the first day, and this is the same exact test for following it like left and right.
Wow.
And again, kind of like what I was talking about before, it's not like I just stood in front of her and I'm like, okay, like look at my thumb over here, follow my thumb. Like we didn't really do a lot of eye movements with her as therapy. And we retested this as a way to look at like is her brain any more stable or higher functioning than what it was. And again, like these last 2 tests here in a second, you'll see as the Optogenetics, which is like the visual motion test here. First one, I believe, goes to the left. And for this, that's what the eyes should be doing. Like they kind of bounce like that.
That's where she's watching the stripes go by.
Yep. So sometimes it's stripes, sometimes like it's red and white stripes. Like there's a manual tape that people recognize as red and white. Our test right now, like when we update the software, it has white and yellow dots go by. But it's basically the same thing.
Same thing.
So that was her, and what happened with her over the course of the week is after the week, in terms of her symptoms, she was about 75% better. Her her blurry vision was absent. Like it went away after I think a couple days. Her dizziness still occurred once in a while. Like if she got really tired, she would start to feel that kind of unstable, disoriented thing. But it was usually temporary if she rested, and her fatigue was much improved. Like she could actually do near normal activities after that week and not be exhausted, and then actually do it, days in a row. Her headaches and brain fog still occurred only when she like pushed it more. Like if she tried to read or she tried to do like more mental or like physical activity and pushed it too much, then like she would have some of that. But after 3 months, like when she was doing her home exercises and check-ins and things like that, virtually gone. She said that like there were still times like once like that last month she had like one episode of like a headache, and that was it. So at that point I tell people, I'm like, it's basically gone, but it's still good to do things to make sure it's like completely zero. But that's a good example where it's a little bit more dramatic, where a lot of people come in like that and they're like they can barely do anything. And then again, like if you do the quote unquote right thing, or you do something beneficial where you can improve the health or stability of the brain, it's like you can change it that quick just within a matter of days.
Yeah, that's pretty powerful.
Yeah. So the next example, this was a young girl. She was 26 years old, and she had dysautonomia, where her like that was her main complaint, where she had similar symptoms to the first person, but she had constant headache, never went away, and she was in a wheelchair or like bedridden. Like she couldn't stand for more than a few minutes. Constant head pressure, brain fog, basically no ability to like memory, concentrate, focus, things like that, and she was just exhausted. So the only reason that I bring this up, because it wasn't, I mean, it could have been a concussion. She thinks that she had it for a long, long time and doesn't know when. She had concussions in her past. So again, it's hard to say,
Right.
oh, this or this is that, but it's a good example of like what dysautonomia looks like. So, I mean, like at least from the eyes. So again, this was the same goggle test, and this test that I'll show you is her eyes in darkness. So the first thing we do on that test is we put people in darkness, and then we watch what their eyes do, because sometimes people's eyes do things that they shouldn't in darkness that you can't see in the light. Like sometimes they can suppress it by looking at something, and then you take vision away, and then you see their eyes do some crazy stuff. So this is her in darkness, like she's not looking at anything, and I'll play it so you can see it. So again, this is just in darkness, where you'll see a couple things. You'll see a slow drifting upwards and then a jerk down. Slow drifting up and then a jerk down. And then towards the end, you'll see something else where both of her eyes start to come together.
Oh, wow. Yeah.
It's called the accommodation spasm or convergent spasm. And I think you'll see it go a little bit more towards the end, like kind of like right there.
Yeah.
So again, I'm going to play that one more time because like there's two things, or there's two things going on in that test. The first of which, it's called downbeating nystagmus, where the eyes will drift up and then jerk down. I think you see that more in the starting. And then towards the end, both eyes together. So again, this test is in darkness. She's not looking at anything. She can't hear anything. She's not moving, nothing like that.
Now, Brian, what should a normal person without any issues, what should that look like?
Because what I tell people is their job is to try to keep their eyes open and look straight ahead. So normally, like if you're doing that test, both eyes should be pointing straight ahead. There might be some fast movements or something like that, but very, very minimal. And it's like your eyes should just stare straight ahead. Basically, any type of movement for the most part is abnormal. But then, you know, some people who don't follow directions, like their eyes are searching all over, but you can tell like, what that looks like versus like something that's like, oof, like that's, you know, that's an injury or something. So I'll play that same test one more time so you can see it. So again, this is her in darkness, and you'll see that downbeating nystagmus there, a few beats like that. So on that, again, like it's more the drifting, not so much like the downward movement, but the drifting up that shouldn't happen. And then near the end of the test, like you'll see it happen a couple times. Like you'll see her left eye there. It'll kind of cross in, like she wants to really converge on that, even though like she's trying not to. And then you'll see it fully happen towards the end here.
Right there.
Yeah, like right there, both eyes just really want to come. So what we did with her is, again, so hers was primarily dysautonomia, where the other thing is, I keep hitting that, sorry, is with her.
Causing all sorts of ruckus.
So with her, really quick, like if you watch her pupils, so with dysautonomia, kind of like what I talked about last year, like the best way that you really evaluate that is through positional heart rate and blood pressure testing, seated, lying, and standing. But sometimes you can even see it in the pupils, where people's pupils will get too big, and it's subjective because sometimes you can't really tell. But if you look at how big her pupils are there compared to the next test when they're a little bit smaller, you can see them go from big to small, or like smaller at least. Sometimes you can see changes like that. But with her, we did a lot of tilting, autonomic therapies, things like that. And I'll show you the same test in darkness, which is her right here. So with her again, you'll see that the downbeating nystagmus is gone. So her eyes don't do that anymore. But the whole time, it's kind of hard to see, but she's fighting that spasm. She's trying really hard not to do it. And when you look at it, like her eyes never really fully come in like what they did, but that's still like her eyes still want to do that in the background. So that's something that I would look at. And I'm like, it's definitely better than what it was. Like it's not as efficient, and even half of it, like the eye movements, drifting up, jerking down, that being gone is really important. So that shouldn't be there either. But sometimes what happens is, again, if it's something that's been there for a while, or it's just really efficient, even when it's better, your brain still, like, it's its comfort zone, like it still wants to do it. So it's important knowing that, though, that it's like it's better than what it was, but it's still not fully stable, where it's not fully gone yet. So then again, like with home exercises and things, we can give people very specific things to do for that. But anyways, with her follow-up, or her outcome from the week, she was about 50% better after the week. She still felt some of the brain fog and head pressure but her headaches were gone. And most importantly for her, she was able to stand and then do normal activities for the most part. Not right off the bat, but like by the end of the week, she could actually, like, she didn't need her wheelchair anymore. She was walking around and doing things. And it still hit her where some of that's just conditioning. Like if you're really not moving around that much, it's going to take more than just a couple of days to get used to standing up and moving and, you know, eating more and like all that kind of stuff, even muscular wise. But she was able to go home and like do a lot more, get back to like her normal life and school and things like that. And at her last follow-up, she was back to normal activities, school-wise, gym and all that, with very, very low brain fog and head pressure. Those are the only two things that she still has sometimes, but it's very minimal, meaning it's like 1 or 2 out of 10, where I think when it started, it was like 6 or 7, or it was like really bad. So again, that was a good example of, you take somebody who's in a bad place, but it's still, because like most people will look at that, they're like, man, I can't even stand up, or I'm so bad. And people are like, I'm in a bad place. This is going to take a long time to fix. But I still look at that. I'm like, if you do the intensive, more often than not, you'll make more progress than what you really would in that. And then the follow-up, like what you can do at home, you'll be much more independent or autonomous doing things on your own than what you would be if it was like one long string of, you know, treatment and things like that. So the next 2 examples that I'll show you are with a different test that we do called the saccadimeter. So what this test does, and why I like it, is this one tests 100 eye movements of a specific eye movement where your eyes jump back and forth. Okay, so it's a good sample size, meaning instead of just doing something like, 10 times, it's a large sample size, so you can really see if, if something is really off or if it's just random chance. But also, it's a good test of a left versus right. Like if you think of it, even though it's more complicated than this, if you think of moving your eyes fast to the right versus your eyes fast to the left, think of it like one's left brain and then one's right brain. Okay, even though it's like the circuits are different. So anyways, what the graphs look like is you can see, or like it graphs out different ways, but the first one that I'm going to show is the accuracy plot, meaning when you moved your eyes, how accurate were you in terms of, did you overshoot or undershoot, or was it right on target? So this one, I'm not sure if you can see the numbers, but basically like you'll see some red lines and then some green lines.
Yeah.
Each one of those lines is one of her eye movements, where the green lines are when she moved her eyes to the right, and every red line is when she moved her eyes to the left. So on this one, what should happen is right around, I'm going to put my finger on it, right around 20, like you might actually be able to see it, right around 20 degrees is where they should land. So if I zoom back out, you'll see that the green ones are landing short, and the red ones are overshooting. And you can even see, I think, on the bottom, like the red ones kind of hook back. So what that's called hypermetria and hypometria on the other side. Also, too, like if you just look at the densities, see how the red ones look thicker, or like there's more red than there is green? She wasn't even able to register all of the green saccades, or like her rightward saccades, because they weren't fast enough.
Wow.
So again, like this is a good sample size where you just see like they're different. The red ones are doing something, or they're landing in a different place than the green ones. So like with her, I'm not sure if I said this, but she was a 44-year-old female, and what she had was, it was found, I forget what symptom she had, but she had some kind of symptom, and then she had an MRI or something, and they found that she had a cyst in her brain. So they removed the cyst, and whatever that symptom was, man, I don't know if it was headaches or something like that, but that like went completely away. But ever since that surgery, she had constant dizziness, constant head pressure, brain fog, traveling body pain. Like it moved almost every single day.
Wow.
And she was really emotional. She's like, one day I'm like crying all day. The next day I'm like yelling at my kids and my husband, and like I can't stop. Like it's just this roller coaster of like emotions, and she has no control over it. So, and then also with her dizziness was more floating again. Like it was just disoriented. It wasn't necessarily vertigo. So with her, hard to say, because again, like she's like, it could be a brain injury. I think it was post-surgery, even though I have no idea why that would happen. But we looked at it, and her cyst was a pineal cyst in the like pineal gland. So the surgery was successful, like they got it out and all that. But then she's like, I got these symptoms, so we're like, okay, like let's test it out, let's see what it looks like. And again, like not just based on this one test, but on her other test, like it was found that she had a cerebellar dysfunction, where this is called a, like with the hypermetria, it's more of a fastigial lesion in the like deep part of the cerebellum. So what we did, because again with her, it wasn't necessarily like an inner ear problem, because like a lot of people hear dizziness and they're like, oh man, it must be like inner ear vestibular, or got head pressure and brain fog, maybe it's like more cognitive or something. Hers was just more cerebellar, where like the cerebellum, I know other people have talked about the cerebellum in other videos from this conference, but the cerebellum kind of coordinates everything. It's kind of, I tell people it's kind of like orchestra, like if you think of an orchestra and you have different like the strings and like the brass and the percussion and the woods or whatever. The cerebellum's kind of like the guy standing in front that coordinates everything. You start, you stop, you play louder, you stop and play again in 10 seconds. He just coordinates everything. So what happens is, like when you see something like this, that cerebellum's not doing its job right. So a lot of the therapy that we did with her was, again, targeted towards that through different ways. And again, after 5 days with her, which I'll go back and forth, but this was the first day, and then this was after 4 days. So again, which I'll go back, where with her, the biggest thing I told her is that the accuracy on these, like they need to be symmetrical again, because again, like they should coincide each other. There should be no difference. But I wanted to see that overshooting go down. So again, like if I go up, you can see where like 20 degrees is. It's like right about, let me see if I can just blow it up. It's right about where the majority of them are. 20 degrees there. So it's good, meaning like she's not undershooting or she's not overshooting. She's like right on the target, which is good. If you still look at it though, there's a good chunk that's normal, but she still has some that kind of skews. So again, maybe not perfect, but like much more stable than what it was. And she was somebody that after the week, she had minimal symptoms, basically gone. I think after Wednesday, they were basically zero, and which was weird for her, because again, like when it's constant, the first time that it's gone, you're like, oh my gosh, I feel really funny. But with her, like she almost flipped, where she's like, oh my gosh, it's back, like instead of like it's still there. So she was at zeros, or like floating between 0 and then 1s or something on Wednesday or Thursday, and then even by Friday, it was like more often than not a 0. So like something like that, even though it sounds bad, because like you think about it again, constant symptoms, you're like, I think her surgery before she came in, I think it was 6 months prior. So like she'd been dealing with it for a while. She didn't know what to do, tried other therapies. And it's something again, like that quick. Like if you can figure out like what got injured, or again, what got skewed, or like what was dysfunctional, that quick. The last one that I'll show you is on the same type of test with the sacchodometer. I'm going to show you 2 different graphs. So it's still the same eye movement, but it's graphed out a different way, where there's still the accuracy plot, but there's also the velocity plot with which is the speed. So you can kind of look at the same thing 2 different ways. This guy, though, he's a 32-year-old male, and he's an athlete. He's a hockey player. And he had, who knows how many brain injuries. He had, I think, one prior, like 2 or 3 months prior, that like knocked him out, tried to wait it out, tried to do different things, and it just didn't go away. So he came in and we did the sacchodometer, and this was the first one. So this is kind of like the new plot, where this is the velocity plot. I'll try to make it bigger, where these ones should basically look like a mountain, where if you're looking at like the speed, they should start, accelerate, kind of hit top speed, and then decelerate, and then land at the target. So on this one, like the most important thing about this is at the peak speed, which is like right here, the green ones reach a much higher speed than the red ones.
Yeah, they're not the same.
Right. So like I told them, something like your brain's doing something where it's either speeding the green ones up, or it's slowing the red ones down artificially, because then you'll see that they come back together. So it's not like your brain thinks that the target's further than what it is. It's not like they overshoot necessarily, but it's doing something, because like the map or some kind of what it thinks it should do is off, and then it kind of corrects it. If you look at the accuracy, though, you can see that when you look at the accuracy, it's kind of like before, where they're different again. And I'm going to zoom in on the target of 20, and you'll see that on this one, the green ones overshoot, and then the red ones undershoot again. And on this one, you can see too that basically like this whole plot, which is again like the same eye movement, they're just like very different. Like the green one's basically over the red one the whole time. So with him again, this is just one test. You can't really diagnose and say, oh, this is what's wrong with you. But just looking at that, you know that things aren't symmetrical, or there's a difference left and right. So with him, we did like a week intensive again. And what I'll do is I'll zoom in. So this was day 1 on Monday. And then this was like the same
Wow.
on Friday. So he's a good example. I'm like, that's what normal should look like for the basically. And then if you go back to the accuracy versus on day 5, it looks like that, where they're almost like superimposing one another.
Yeah.
And that's how it should look. Meaning like there should be no difference. There should be no difference left and right, and it should be very consistent. Meaning like again, these are 100 eye movements, so like 50 left, 50 right. Each time, like if I asked your brain to, hey, do this 50 times, it should basically do it the exact same way 50 times. So it's a good test of stability and consistency of, is that brain healthy enough through fatigue and just mechanisms of integration and processing? Can it do the same thing 50 times? So with him too, after the week, he was like symptom free, like he felt awesome. He was someone too where usually with hockey players, like if we get that kind of response, we put him back out on the ice, because he was someone when he would skate and he would turn around the boards and he would get that like visual motion.
Yeah.
He would just feel awful.
Yeah.
I'm not sure if I said this either, but his symptoms were constant brain fog again. He just felt like really spacey, and he could just never like focus. Very disoriented, unstable on his feet, kind of unsteady. And he felt very uncoordinated. He's like, when I play hockey, like, passing, shooting, looking down, looking up, like everything was like segmental. He's like, I'm so slow, or like, I'm so, step 1, pause, step 2, pause. And then his like cognition, he's like, when the coach is telling me what to do, or like the teammates are like, we got to do this, he's like, what do you, he was just spaced out. He's like, I can't focus, especially after like exercising pretty hard. So anyways, after a couple of days, he felt really good. So then once you had him go skate and practice and stuff, and he felt really good on the ice with no breakdown. So he's a good example of, again, it doesn't always work like that.
Yeah.
Basically symptom free in a couple of days. And then after leaving, went right back and played with no issues.
That's amazing.
Yeah. So again, all of those examples, like why I wanted to pull those is it's a good example of, sometimes people hear it and they're like, yeah, it sounds good, but does it actually happen? Like, is there any chance that could be me? Or, sometimes just seeing it, like it makes it more real instead of just, I heard this one guy this one time got better or something like that. So it's something that, again, like all of those people, if I can go back in time and they ask me, should I go, do these 15 hours of treatment over, a longer period of time, or like, would I be better doing it more concentrated in 1 week? I tell them do the week, because to me, like that gives them the best chance or the best probability to actually, get the most benefit from the treatment and hopefully make the best progress.
Yeah. Another question, well, not so much a question as a statement I get from people is, okay, I think I'll do it. They've talked to Lori and they're like, okay, I'm going to wait till summer. I'll have more time in the summer. And I'm like, you're going to regret waiting. Because I've met so many people who've come in from my tribe, and they waited. They put it off like a year and a half. And then they finally, because they just don't believe it could really work, or they don't think they could handle it. They want to wait till they feel better so that they can go do it. And then, every single one of them's like, oh my God, why didn't I just do this? Like, it was life-changing. So, that's always my advice to people is, no, don't wait. Do it now. You're never going to feel better. It's never going to be a good time to do it.
Mm-hmm. Well, that's the truth. I feel like the only thing I would say on that point is, sometimes people are like, like there was a accountant one time or some kind of financial person, and he came in just to get examined to see if he was a good candidate. And he, like we found some stuff, and he's like, okay, should I come in? And I'm like, what's your schedule look like? And it was like tax season or something like that. He's like, oh man, like the next 3 weeks are slammed. And I'm like, wait 3 weeks and then come in.
Yeah.
Like if you're super stressed and things like that, I'm like, pick a time, preferably sooner rather than later, but still a time that you can like really dedicate and you can really just focus. Like that's my number one goal. I don't have all these other priorities or all these other things. Sometimes it's hard to do that, but at the same time, if you pick a time that you're like the least stressed, where you can really like dedicate that amount of time and energy and, mental focus on like what we're doing, it works a lot better.
Yeah, absolutely.
Mm-hmm.
Well, Brian, this has been awesome. Thank you for sharing all this. And I think having those eye movement things, I think that's just so beneficial to like see it.
Yeah.
So it's one thing to talk about it, but then to see it, I think is so helpful.
Mm-hmm. You are welcome.
Well, thank you for being here again this year. We love having you here. And thank you everyone for watching. I really hope you enjoyed this episode. And just a quick reminder, if you're not able to watch all the live videos in March, you can purchase the recordings for $29 with proceeds going to the Love Your Brain Foundation. So thanks again for watching, and we'll see you in the next episode.